Hi, my name's Anthony Glover. I'm an endocrine surgeon and an associate professor of surgery at the University of Sydney. It's great to be with you today in Korea to talk about active surveillance of small papillary thyroid cancers in Australia. I have no conflict of interest to disclose. So, in my role at Sydney University, I run the Master of Surgery program, and we have a research group that extends from the university also to the Colling Institute and also to my clinical practices at St. Vincent's Clinic. And our group really looks to understand or to research endocrine cancers, surgical outcomes, and surgical education. And we seek to do that to improve outcomes for patients and to better understand the biology of different diseases. Our main focus in endocrine cancer is in thyroid cancer. So thyroid cancer has become increasingly important in Australia. It is now in the top 10 most commonly diagnosed cancers, and there's more than 4,000 cases of thyroid cancer. The incidence is well over 12 per 100,000 people, which compares to Korea, which has around double the incidence. But as we can see, while incidence has increased greatly over the past few decades, mortality has stayed stable, indicating that there is overdiagnosis and that many indolent thyroid cancers are being diagnosed. So how does thyroid cancer present in Australia? There's no uniform pathway. Most patients will present, especially with small thyroid cancers that are found incidentally on an ultrasound, which has been performed for another reason. That commonly may be due to a cough or some other symptoms of the head and neck. This is usually organized by a family doctor or a GP, and the patient may or may not have had a fine needle aspiration biopsy. Patients are generally referred to surgeons for review. That may be general surgeons, ENT surgeons, or endocrine surgeons, which have varying levels of thyroid interest and experience. And many surgeons will include thyroid cancer practice as part of other specialties such as surgical oncology with breast surgery or melanoma, or head and neck surgery or other ENT specialties. Patients may also be sent to see endocrinologists who also will have a varying amount of experience with thyroid cancer, and many endocrinologists, the majority of their practice would be made up of management of obesity or diabetes. So that means that the patients will see specialists with different levels of experience and different levels of knowledge of the current management of thyroid cancer. Also complicating active surveillance in Australia is that there's a high incidence of multinodular goiter. Australia is a geographically iodine replete area, and iodine is added to salt, but many patients, especially older patients, will have an underlying multinodular goiter. One thing that has been adapted in Australia in the last few years is the widespread use of the TIRAD system. So most radiology practices will include the TIRADS recommendation on an ultrasound report, and those recommendations will often be followed by a family doctor. So how common is active surveillance in Australia? We don't have any formal data available, but it's likely less than 5% of diagnosed thyroid cancers are treated with active surveillance. And active surveillance is generally offered by some surgeons and some endocrinologists who have a particular interest in thyroid cancer. But we really don't know how commonly it is done, just due to the fragmented system we have in Australia and differences in collecting data on thyroid cancer presentation. But while active surveillance, it does have a limited use, it is practiced, and active surveillance is widely known to be a management option for small papillary thyroid cancers. And the reason why it is well known is due to a couple of reasons, two of which back in 2015, Professor Akira Miyachi was our section visitor at our Australian New Zealand College of Surgeons meeting and gave a keynote talk on active surveillance and their experience since the 1990s are performing active surveillance for patients in Kuma Hospital in Japan. And that year as well, so 10 years ago now, the American Thyroid Association guidelines suggested active surveillance could be a treatment option for patients instead of surgery with low risk thyroid cancers. And the American Thyroid Association guidelines are the ones most widely used in Australia. So I think due to this increasing awareness and the impact of these guidelines, most clinicians will be aware of active surveillance. But what are Australian patient attitudes to active surveillance? Multiple studies, especially internationally, have shown that for people with low risk thyroid cancer, or for people who are presented a scenario of having a low risk thyroid cancer, most will choose active surveillance. So some studies that will be up to 80% and others are around 50%. This recent study, which was done by Chris O'Neill's group in Newcastle in Australia, was a study where they presented 150 patients who either had low risk thyroid cancer or benign thyroid nodular disease with a discrete choice experiment. And it used a scenario of a 50-year-old woman, a patient, with a small thyroid cancer, and the participants were asked to choose between 3 treatment options with 10 different kind of ranges of possibilities for each treatment. And these risk profiles varied against voice change, the need for thyroxine after treatment, a low calcium, chance of further or a thyroid operation, and a 10-year risk of recurrence. And what this group found was that when patients are presented with these risks, about half would prefer active surveillance, and half would prefer surgery. So kind of consistent with international studies that many patients would choose active surveillance if it was available to them. But we know the clinicians are not practicing active surveillance that commonly in Australia. And why is this? So this is another paper that was done by another endocrine surgeon in Australia, so Dr. Laura Wang. And she performed a survey looking at what clinicians and their attitudes were to active surveillance. She sent the survey out to members of these societies, so the major surgical societies and endocrinology societies in Australia and New Zealand who treat thyroid cancer. And from 110 responses, she found that only about 2/3 or a little under 2/3 of clinicians would actually discuss active surveillance with a patient diagnosed with a small thyroid cancer. And less than half had managed patients with active surveillance in the past year. Given this study was performed in 2021, I found this quite surprising, especially that not all clinicians would discuss active surveillance, given how well known it is to be a potential treatment option for patients. From the study, the team found that clinicians who perform ultrasounds are more likely to utilize active surveillance. And from the responders, they found surgeons were more likely to discuss it compared to endocrinologists. So why is this? And I think looking down further into these results, what I find interesting was, 1/3 of clinicians would recommend immediate surgery for a small papillary microthyroid carcinoma, and another 1/4 would discuss both active surveillance and surgery and recommend surgery. And the reason, indications for surgery being for higher risk cancers, which is reasonable, but also for patients who are young, and about 40% of people would recommend surgery for all biopsy-proven papillary thyroid microcarcinomas. So I think in Australia, we have a gap between awareness and practice. This is an example of one of our education cases, which is part of the Australia-New Zealand Endocrine Surgeons training program. So this training program is for surgeons who are doing a fellowship in endocrine surgery. They're fully certified, fellowship trained general surgeons. and they spend 1 or 2 years doing further fellowship training, and they have a number of education modules, of which this is one. So in this case, it presents a 40-year-old woman who's presented for an incidentally found Tyroids 5 thyroid nodule, which is 9 millimeters in size. She has no obvious high-risk features. Her voice is very important to her. She leads her church choir, and she wants to know about, and she comes to see you for further treatment. And so the fellows in our program asked how they would manage this patient, and if active surveillance would be a viable treatment option for this patient. And what is surprising, that nearly all, or generally more than 3/4 of the fellows, would say active surveillance is contraindicated for this thyroid nodule if it was found to be a thyroid cancer on biopsy due to extrathyroidal extension. But you can see here it's on the anterior capsule of the thyroid, and while it is pushing out into the muscle, there isn't any obvious invasion. And really like to thank some of our colleagues here in Korea who are really starting to work on specifying which patients could possibly be suitable for active surveillance. And for a patient such with the ultrasound in this case, this nodule would be appropriate because there isn't, while it abuts the capsule, there is no obvious extrathyroidal extension. So I think there's a gap between what clinicians understand about active surveillance and how to practice it. So once again, in this survey from Dr. Wang, about 60% of clinicians were concerned about the patient's anxiety about a cancer diagnosis as to whether they offered active surveillance. There's also concern about medico-legal risk, about how patients would be followed up, and potentially about compliance. And talking to clinicians in Australia, you get very varied opinions about whether active surveillance is appropriate or not. So these are some quotes that I have heard during my time, but saying active surveillance is too much hassle, it shouldn't be offered in younger patients, and some surgeons would not feel comfortable offering active surveillance unless they were supported by another clinician, such as an endocrinologist. So there are definitely barriers to practicing active surveillance in Australia. One factor that wasn't covered in this survey, but I think is obviously an issue. Another issue with active surveillance is the way surgeons are paid in Australia. Most surgeons work between the public and private system, and in the private system, they have to fund their clinics and their administration and all the other practice costs through the fees they earn through their operations and through seeing patients. And this shows the kind of different surgeon payments that you would receive for a hemithyroidectomy, from the kind of Medicare Australian government rebate, which is around 800,000 won, up to the recommended fee from the Australian Medical Association, which is more than 2,000 won. And this compares to surgeon payments for follow-up appointments, which would be around 90,000 won as the Australian Medical Association recommended fee. So while these issues are not obvious, I think they obviously also create some bias and potentially influence what treatment patients are recommended to have. But I think we know, and I know with previously at this meeting in 2020, Dr. Brooke Nicol, who's a public health researcher at the University of Sydney, who's very interested in patients' choices for cancer treatment. And we know that the old kind of dogma of how thyroid cancer is treated with a total thyroidectomy and radioactive ablation and TSH suppression is not appropriate for many patients, especially most patients or all patients with a low-risk thyroid cancer. And I think the standard of care for these patients, most clinicians would agree that patients need to have a risk assessment and have a process of shared decision-making where their different treatment options are discussed and the patient is able to choose which treatment suits them best with their preferences, and obviously also their risk factors and the risks of the cancer. So I think in the future, active surveillance will become more part of the practice, but we need probably to do more to help clinicians to practice it. And so one way we're trying to do this is with some of our research. So Dr. Ellie White is an endocrinologist who is currently doing a PhD at the Colling Institute with Dr. Maddie Guild. And she has developed a REDCap web-based support tool to try and help clinicians identify patients that would be ideal for active surveillance. And with this very simple tool, which includes a number of clinical and radiological findings, she was able to show that if this tool had been used in a group of patients who had previously been treated with surgery, about half would have met the criteria for being an ideal candidate for active surveillance. Ellie also showed that from these patients and their median follow-up, none of them had any evidence of disease recurrence, which would be expected for these low-risk patients. Dr. White is currently studying this tool in a prospective randomized study where clinicians are randomized to use the tool with either receiving the recommendation or just some general information about low-risk thyroid cancers. So I hope in the future, this will help clinicians be able to identify and practice active surveillance. Also, we're trying to improve the evidence base of active surveillance in Australia. So we are very fortunate to be part of the Maestro extended study, which is following on from the Maestro study, which has been conducted in Korea. And in the extended study, it is including 5 centers from Australia, and also recruiting recruiting patients with cancers up to 1.5 centimeters, and providing a very rigorous and very standardized criteria for how these patients assess for risk and disease progression. And I think one interesting part of this study is including volume as part of the data and looking at volume increase as the indication for progression. And a couple of years ago, Krishna Vickerson, who was an honours medical student at the time, did this research project with me, looking at the relationship of volume of small thyroid cancers and their association with higher risk features. And I think one of the kind of striking things from this study to me was how much variation there is with volume. So you can see here from this figure in the box, cancers between 1 and 1.5 centimeters maximum dimension. And as you get bigger, there's a much greater increase in the variation of volume. So cancers around 1 centimeter have a volume that ranges from a couple of hundred millimeters cubed up to 500, whereas 1.5 centimeters can range from a couple of hundred up to almost 2,000 millimeters cubed. And what we found from the analysis in this study was a volume over 350 millimeters cubed was associated with lymphovascular invasion, and also other kind of higher risk features such as more than 5 microscopic lymph node metastasis. So hopefully with the Maestro extended study, including volume, we'll get a better idea of if volume could be suitably used as part of a clinical assessment for patients with small, low-risk thyroid cancers. So I think the future of active surveillance in Australia will increase as our practice changes. As with many places, especially in the city in Australia, there's increased specialization. And I think for some clinicians who are interested in thyroid cancer, there's a move for patients who treat thyroid cancer rather than and do follow-up rather than being confined to a specialty. There's increased acknowledgement and use of shared decision-making and clinical decision aids, which I hope will help this process in the future. I think the medical legal impact of the increased knowledge of active surveillance will be the opposite of what is feared, that potentially there will be medical legal implications for patients who have complications or outcomes of surgery that they're not satisfied with if they were not offered active surveillance for small, low-risk thyroid cancers. In the future, I think there's the potential for government and health policy changes if we continue to not ensure that our patients understand their treatment options and offer treatment that is that is expensive and that does not provide a good return for investment. In the future as well, I think we'll have better risk stratification tools, potentially use of molecular testing as well could help identify which patients should have which treatment. And I think there's definitely a possibility of developing new types of systems for reporting of ultrasounds to identify small, low-risk cancers that would be suitable for active surveillance. So thank you for listening, and look forward to your questions to cover how active surveillance is practiced in Australia. Thank you.